Hi, my name is Jacqueline Barrientos. I work at the Northwell Cancer Institute in Long Island. And the topic for me to discuss is what are the current challenges when selecting a chemotherapeutic agent or a targeted agent for our patients with a diagnosis of CLL. So there are several challenges because, as you all know, CLL is a very heterogeneous disease. And in some patients, it can be very aggressive, and in some other patients, it might be more indolent. Similarly, patients with a diagnosis of CLL can have um, a lot of comorbidities that may affect their ability to get a particular therapy regimen. So the first thing you have to do is do the prognostic markers for the patient before you start therapy. So the most important one is you have to know the status of TP53 mutation or deletion 17p. If you have that, that patient should only be treated with a targeted agent, either a BTK inhibitor or a BCL2 inhibitor. If you don't have 17p deletion or TP53 mutation, then you have to divide the patients into fitness and tolerability and patient's desire for either continuous use of therapy or fixed duration therapy. So if you don't have 17p deletion and your patient is fit and young and healthy, you can discuss with the patient the possibility of using targeted regimen such as ibrutinib or acalabrutinib, which is a continuous drug taken, until progression of disease or tolerability issues. Or you can offer the patient the possibility of using venetoclax with the monoclonal antibody of inotuzumab, which is a treatment that you get for 1 year and then you stop. The other option is FCR or BR. Now, you have to consider that the data for unmutated IGHV disease seems to show that patients do better with targeted agents when they are treated with targeted agents rather than a chemoimmunotherapy regimen. So chemoimmunotherapy regimens are kind of like being relegated to just a very select group of patients. Which one would it be? For example, a patient that is young, healthy, and has no major comorbidities with a diagnosis of CLL, without 17p deletion, without 11q deletion, that has mutated IGHV, that patient could be offered FCR because the likelihood of the patient is high for the patient to achieve undetectable MRD state. And if that is the case, the patient can expect that 2 out of 3 times they might still be in remission 10 years later. The only problem with using a regimen such as FCR is that the patients have a lot of myelosuppression and severe infection risk. And that is difficult because of the current pandemic that we're living with COVID. We try to protect our patients from chemotherapy as much as possible because in some areas of the world, COVID is making the rounds, and the more exposure that you have to an infection, or potentially drug that can cause you to be more susceptible to infections, it's harder to tolerate. Particularly because this chemoimmunotherapy regimen does better when you complete the 6 cycles of regimen. Now, if you choose a targeted agent, which is what most of us are doing in the United States, if the drugs are available for our patients, then you have to make a choice whether you want the patient to receive a BTK inhibitor such as ibrutinib or acalabrutinib, or BCL2 inhibitor as venetoclax, which is approved in combination with inotuzumab. Both treatment strategies are completely different. Ibrutinib and acalabrutinib are given indefinitely until progression of disease or tolerability issues, and they work really slow. It takes time. What happens initially is a redistribution lymphocytosis phenomenon. The lymph nodes shrink, then the hemoglobin starts to go up, and the platelets start to go up. But you take the drug indefinitely for the rest of your life. So that might not be something that is a good selection for certain patients that may not be very compliant after 2 or 3 years on therapy. So then the other option is venetoclax with inotuzumab, which is a regimen that has been determined to work really well for only 1 year of use. The only issue with the use of venetoclax is that you have to use dose ramp up straight treatment strategy where you start off with 20 milligrams and next week you go up to 50 milligrams and 100 and 200, and then the target dosing is 400. So it might not be appropriate or easy for certain patients, because then they might need to come more often just to get tested for electrolyte abnormalities, because the drug could cause tumor lysis syndrome. And so for certain patients, that might not be the best option of care in this era. But other than that, you know, both drugs are very well tolerated, BTK inhibitors, BCL2 inhibitor, but you have to be aware of the potential toxicities. With BCL2 inhibitors, tumor lysis syndrome is the most concerning side effect and toxicity, whereas with BTK inhibitors, we can have issues with bleeding, atrial fibrillation, or cardiac arrhythmias. And over the long period of time, patients can also develop hypertension or arthralgias or other quality of life issues. So you have to have this discussion with the patients. And overall, we are very happy to be living in an era where we have access to targeted agents for the majority of our patients. And so we can offer them good outcomes, because these drugs are very efficacious, with the possibility of trying to minimize the potential for toxicities. So these are essentially the challenges that we face for our patients. Thank you.